Appreciate that, but maybe a little hard fought. But I'm glad he talked about the political side for a minute, because we hear on the news every day stuff that's going on in Washington and all the things. But I got a little cartoon I wish I could put up here, but it's a picture of two surgeons walking into the operating room, and they're all gowned up and ready to go to surgery. And one physician says to the other, "To think I spent all those years in medical school when I could have become a healthcare expert just by running for Congress." I thought that was pretty good. But I want to talk a little bit about something that has really disturbed me lately, and it's dispelling the myth, and Mike mentioned it, that independent physicians are becoming employed physicians at a rapid rate. You guys all hear that, right? And you know who's pushing that? The American Hospital Association. They want docs not only acting, physicians that are out there today, but they want these young physicians coming out of medical school to believe that it's their only choice. And recently, for the first time in the U.S., it was announced that employed physicians outnumbered self-employed independent physicians in a study that was released last month in conjunction with the American Hospital Association and the American Medical Association. Well, let's set aside for a moment this finding, which, by the way, the American Hospital Association deemed a milestone. Well, if this is an accomplishment, well, it was based on a very small sampling of doctors. This is where fake news is at its finest. This survey that the American Hospital Association did surveyed 3,500 physicians in America, and only 36% of those 3,500 physicians responded to the survey. So we've got 1,260 physicians representing over 1 million physicians in the United States. That's less than 0.1% of the population. And that's a statistical stretch at best, wouldn't you agree? But other reports say that 1 in 3 physicians today are only independent. Well, regardless of the rate of doctors foregoing independence and for a steady paycheck is continuing, the trend is not healthy for doctors, it's not healthy for patients, and it's not healthy for America. And I'll tell you why. There was a newspaper article on Monday of this week. The local front page of the news section was a picture of Daryl Toll, President and CEO of Orlando Health, and it stated, "New law will hasten hospital building boom." Did anybody see that article in the paper? Oh, it's just fried me. Because it talked about the 3 hospital systems, mainly Orlando Health and Advent Health, talking about all the new stuff they're going to build that's going to improve healthcare access in Orlando. And 10 years ago, there were no such thing as a freestanding ER. Today, there are over a dozen of them just in Orlando alone. There are over 125 urgent cares in the Metro Orlando, the seven counties, and over 90% of them are owned by hospitals. That's pretty staggering. Why should we worry? What does it matter? Well, when hospitals or private equity groups buy doctors, costs skyrocket, quality goes down, and if the hospital doing the acquiring is nonprofit, this is even a bigger problem. Communities suffer financial harm because the taxes that those independent practices were paying are now off the rolls of the taxes. And I can tell you, Florida Hospital, with a $9 billion a year revenue stream, pays no taxes. $9 billion a year revenue stream. They're the 4th largest grossing revenue hospital in the United States, and they pay no taxes to our community. Also, when doctors become employees, they suffer burnout much greater than the independent physicians. And today, I was really shocked when I saw this statistic. Today, the suicide rate among physicians is the highest of any profession. Did you know that 1 physician dies by suicide in the United States every day? That shocked me. And the corporatization of medicine is part of the problem. And I think you guys understand that. Yet hospitals continue to roll up doctors. Why? For money. The more doctors that hospitals or even these private equity groups can own, the more market share they capture, the more bargaining power they have with insurance companies, the more facility fees they can charge. And that's a fee that is charged by a hospital that can't be charged by an independent physician. And the more market share they capture, the more bargaining power they have. And the more referrals that they can assure that go into their own system at extremely high cost. Well, and you know, this all adds up. There was a study recently by healthcare research, you may know him, Merritt Hawkins. They did a study in 2019, just in April, and it reported that hospitals make on average, you're not going to believe this, $2.4 million net a year on every physician they employ. No wonder they want and can afford to lure doctors into employment. Many doctors, due to the burdensome regulatory and adversarial payer relationships that an independent physician gets, often regret it later. And what happens when they regret it later? When they want out, they find themselves in a no-compete situation where they either have to move, leave all their patients, or stop practicing altogether, or just stay employed. I think this was a very, and also this report stated that physicians, the employed physician population was growing at 6%, while the independent population was declining at 7%. Well, that is an important statistic, but let me tell you what the real numbers in this survey were when you looked at it. They talked about this model going from 2012 to 2019 to today. Well, from 2012 to 2014, the growth that they're talking about in the independent environment, moving towards hospitals, happened all in 2012, 2013, 2014. Nobody said that from 14 to now, there has been a mass wave of physicians leaving the hospital and wanting to go back into independent practice, as Mike mentioned earlier. And, you know, again, why would a hospital want you to know that? Why would they want residents coming out of medical school and residency and fellowship to know that? Well, I think we're witnessing a move towards employment slowing, no question, and the tide is beginning to turn. And guys, this is huge information. I've been working with independent physicians for over 25 years, and the tide is beginning to turn. There was an 88 physician group in Charlotte, North Carolina that recently left one of the largest health systems, Atrium, Mike shaking his head, up in North Carolina, and they stated the reason we want out is we can better control how we practice medicine and our destiny as a physician. That was number one. And then there was another 42 doc group in southern North Carolina that left the Novent health system recently, citing to make health care more affordable. They understood it. And they left a group called, and there was another group in Wisconsin that left Theta Care, a major health system in southern Wisconsin, stating a desire to have more control over all aspects of their practice. Have you read this in the paper anywhere? I don't think so. In addition to all these exits, we hear daily from doctors, and I get a call almost every month from a physician wanting to convert their practice to a direct care model or the concierge medicine. And what that's about is they want to opt out of the payer rat race and bring down costs and eliminate the burdens associated with dealing with insurance companies. That's one of the main reasons a physician, if you're an independent practice, should join what we do. You know, these newly independent physicians have a desire to practice medicine and provide a product for their patients under their own programs. And I think the certainty that they're at the forefront of a new trend of medicine, which is called value-based care in population health medicine. That's where everything is going today. And I want to talk a little bit about what that really means. But the numbers only tell part of the story, as you can see. The rest of the story is that independence is not a thing of the past. It's not eroding at massive levels to where one day you're going to wake up and your own opportunity is going to be go to the hospital. But it's the future of medicine. And independent physicians are the solution to spiraling out of control healthcare costs. We at IPN, we represent over 1,500 independent physicians now in 11 counties and growing. We just added 650 docs to our almost 1,000 doc group just recently up in Gainesville and Ocala. So we're all the way from Gainesville all the way to Point St. Lucie. That's kind of our area. But, you know, we're doing things like commercial shared savings. Mike mentioned quality metrics and quality scores and all that. This is the way we're going to bring these talents and skills to independent doctors so they can compete. It's estimated that 50% of all physician reimbursement is going to be based on value-based care by 2020. That's next year. Next year. And we're seeing the massive movement now. We're already in a big contract with Cigna, almost 35,000 lives. And last year, and we just started our 4th year with Cigna, we have returned over $1 million to our doctors in the first 2 years. And that's found money. They still bill and collect everything they do all year long under their own independent Cigna contract. And on top of that, we give them bonuses almost $1 million. Imagine a primary care doctor who on average may make $175,000, maybe $200,000 a year. That's the low end of medicine, getting a $35,000 or $40,000 bonus. That's huge to your independent physicians, particularly the primary care guys. We're doing Medicare Advantage risk contracts. We have an MSO. We are rolling out, Mike mentioned, Alliance Health Partners. You know, you got Advent Health, you got Orlando Health. Now, welcome to Alliance Health. And you're going to be hearing more and more about that. This is a direct-to-employer program where our doctors are going to direct contract with the large employers. And we have 27 employers that have already said we're very interested to hear. We're just finalizing all the details, and we're going to roll this out September 1st. So be looking for Alliance Health Partners in the future. We're also building some medical villages. You know, they talk about the boom on hospitals. Well, we've already got 5 sites that we're going to build independent medical villages, and they're going to include outpatient surgery, urgent care, imaging, lab, pharmacy, rehab, and then some independent physician practices, both primary care and specialist. And we're building one in Oviedo. We hope to break ground in the fall. And we're building one in Ocoee, one in Winter Garden, and 2 in Kissimmee. And that's only the beginning. And when have you heard that independent physicians are expanding their footprint in a community versus hospitals? It's just not heard of. It's just unheard of. Well, you know, we're providing the tools and the programs if independents want to maintain independence to help them compete in today's healthcare environment. And you know, we just celebrated America's 243rd birthday. Well, I thought it was interesting that while we reflect on our nation, why don't we reflect on the history of healthcare during that 243 years? And I thought this was kind of interesting. 169 years ago, the first accident insurance was written. 169 years ago. 107 years ago, the first presidential candidate actually campaigned on universal health care. 109 years ago. 107 years ago. 90 years ago, the first employer-sponsored hospitalization prepaid health plan came into existence. 74 years ago, the states were granted power to regulate insurance companies. 53 years ago, and many of you know this, Medicare was formed to create insurance for the elderly and the disabled. And that was in 1964 under Johnson. 9 years ago, PPACA, the Patient Protection Affordable Care Act under the ACA, which Mike just mentioned, is probably going to get killed next week, if not because it looks like the Supreme Court's going to vote it down, was created this 9 years ago, 2010, to create federal standards to improve quality and access. And you know, stay tuned because who knows what's going to happen next. Nobody has a crystal ball. And you know, I loved the theme of Seacoast Bank where it said, taking care of you and your community. And I really appreciated the 2 testimonies from the people with CBD this morning because you know what? Isn't that what it's all about? We take care of physicians, but it's all about us taking care of each other. And I just want to leave a couple thoughts with you. When we as the leaders of healthcare or whatever your industry is in, you know, leadership is not being in charge. It's about taking care of the people in your charge. Think about that. And you think, well, how do I direct people? Well, people don't decide their futures. They decide their habits. And their habits decide their futures. And we can be the ones that help mold that as we go forward. You know, I hope you spend every day taking care of your family, your friends, and your colleagues, and go out and help someone tomorrow. Thank you so much. Any questions?
Thank you, Larry. Mike's going to jump in, and I think you two can figure out.
Okay, good. Love to.
Okay. We've thrown a lot at you tonight, and I just want to tie a few things together with Larry's help. You know, I've done this for 23 years as a lawyer, and 3 years I clerked for DOJD in law school at the University of Alabama when I was there at law school. We've seen so much change in healthcare, but really in this period of time, that 26 years, this is the biggest shift I've seen. It starts with, look, I'm not going to tell you if I'm a fan of the ACA or not. It really doesn't matter. I'm a lawyer. I have to do a job to interpret things. I like the concept, though, of going to protecting the patient. That's what this is all about.
That's what it's all about.
Your Hippocratic Oath.
Yep.
You've been taken out of that as doctors. With value-based medicine, it's going to come back because patients are going to seek value. They're going to seek care. An IPA can go to the big payers. Who benefited from the ACA? Did the patients really benefit? No, all of our premiums went up. Did any of the doctors in the room, did you get higher reimbursement rates?
And the taxpayers paid for it.
The taxpayers paid for it. Who got all the money? Well, there's some large lawsuits by Humana and a few others to recapture their $353 billion subsidies. It's the insurance companies. With an IPA, you get like this, with an IPN, with an allied health partners, structure, you get to negotiate. You have the power of 1,500 doctors negotiating rates with a company like Cigna. It's called a black box messenger model. It's a very simple model and it's very effective. You get the ability to, instead of having to go in your office and do all the quality metrics, and Cheryl and Marianne and Celia can tell you all about this if you haven't had a first-hand experience with it, of dealing with how, what was the PQSA or not the
PQR. PQRS.
You have PQRS. You have a back office now that does this, and it not only takes your quality metrics, it takes it across 1,500 doctors, and it can take it across and work with the insurers on a secure, cyber secure type of environment where data can be aggregated and used.
Let me mention one thing while you're mentioning that. You know, I didn't tell you about our Cigna. In year 3, we ended up our year is April 1 to March 31st. So we just completed our 3rd year as a Cigna. It's called Collaborative Accountable Care. There are 240 in the United States, 20 in Florida. We're one with our 35,000 lives. And as of April 1, we were the #1 performing Cigna CAC in the country in both cost and quality, which is unbelievable. And that proves that independent doctors, we're doing it 10% below the entire book of business of Cigna in this community. And the hospitals are doing it 12 to 15% above the market in CACs that they're involved in.
So why are doctors leaving hospital employed in big network environments? They can't get what they want in terms of, first of all, interoperability, sharing. I've had plenty of clients, and what he said about 2014 is true. I did lots of deals. Clients came and said, the economy was bad, we can't afford our EMR, this interoperability, the software, it's going to kill us, we got to go in-house. Okay, well, they've got in-house, they've signed deals. The last one I did was 2014. In 2017, I started getting the calls, and add that up. Now look, I'm a Naval Academy grad, so I can do math. Just because I'm a lawyer doesn't mean I'm completely stupid. I have a BS degree when it comes to math, I can add numbers. All right, what's 17 minus 14? 3 years. What are most physician guaranteed contracts in a health network? What's the term of that? In a health network or in a hospital? 3 years. They're all coming due, the 3 and the 5 years. So what they're hearing now is, well, you know, Dr. Jones, we really don't want you to, we want you to supervise those ARP and PAs because there's not enough of you.
Right.
So we got to
That's right.
supervise
That's
them, but we got some concerns about that Halifax case that settled and that Toomey
right.
case up in South
That's right.
Carolina and the Stark and the false claims and the big Advent Health settlement. So we're not going to pay you to supervise them anymore. We don't want to mess around with Incident 2 billing. How many of you do Incident 2 billing in here? Okay?
Yep.
So we're going to cut your pay, but you're still going to have to supervise. Well, if you're a doctor, and Brian and I do med mal defense, we do a lot of it, you're liable for supervising them. Okay? Oh, and by the way, we're only going to give you $257.50 on your insurance.
Well, there's one other thing.
Right.
With value-based care going where it is, the hospitals want to buy up all the primary care doctors because that's how the lives are attributed, and they're not going to share that shared savings with the doctors. They're going to keep it in-house. We give 90% of our shared savings back to our doctors. And I can tell you, I know hospitals that have given 30% back, if that, today.
So what they're looking at is, we're going to tell you how we want you to practice. We're going to put more burden on you.
Yep.
We're going to cut your pay, or we're going to go to Pure Eat What You Kill, which if you're going to go to Pure Eat What You Kill, work for yourself.
That's right.
Okay? And get the back office support you need with a good, strong team internally, and look for a good, strong IPA, IPN, MSO type of network. The other fun thing for them is they're hearing now that, this just hit me, on the value-based, so they come in, and if you've ever seen these hospital or health system contracts, they have these 5, 6, 7-page formulas. Brian and I see them all the time, and we're sitting there, we're whiteboarding them, and well, if you do this, is you going to get clawed back here? Is there going to be a refund there?
That's right.
What CPT codes go into your RVU base if you're going to go on that model? By the time you get done figuring that out,
you won't figure it out.
you won't figure it out. And then you got to ask for the numbers. Well, ask any doctor you know that's employed at the big, and look, I'm going to take my chances. I don't represent the hospitals.
Right.
But ask them if they're employed, how easy it is for them to get their productivity, their quality scores, all the things that they do. Okay?
Let me throw something in here. That's how strong they're out there trying to make it like it's a good deal. The only good deal out there is keeping independent physicians independent and giving them all the tools to be successful in the community. Because now we're taking care of patients. We're providing a healthcare product at a lower out-of-pocket cost, at a lower overall premium. Everybody wins.
Tell them the types of reports that your doctors get and how easy they are to read.
Oh yeah, they get they get monthly physician scorecards, and that physician scorecard tells them how they're doing based on cost. It shows them who their ER flyers are. It gives them who their admissions and discharges are on a daily basis. We have an RN that does nothing but call every office for every patient in our Cigna program that is either discharged or admitted that day, and we set up a care program so that the office gets involved. Because I can tell you, most primary care, they don't even find out that their patient was in the hospital till 2 or 3 weeks after they were out. And if you're not back, if it's a chronic care situation and you don't have a PCP visit in 3 to 7 days, chances are within 30 days that patient's going to end up back in the ER in a readmission. You know what our readmission rate was last year? For an entire book of business with Cigna, 4.6%. That's incredible. Cigna can't even believe it. It's all about giving our docs the tools.
And that's one of the things, truly, when one of the patients goes into the hospital, the fact that they do not communicate well with the primary care, and they're replicating tests that have been done. Again, as you say, the productivity of a physician in the hospital system is about 24% less than it was. Now, they make up for it with, of course, all the ancillary things and that facility fee. But yet, the doctor eventually gets docked for his productivity, even though they're making, as you say, $2.4 million from all the tests and referrals within that system. But the communication before, and then your patient looks at you when they get out and calls in, and now there has not been any reconciliation of medicines.
No coordination of care, nothing.
And it's just absolutely terrible.
Well, you know, the other thing that we do is our primary care docs, we make sure that they have an assigned hospitalist for inpatient care. Because if not, the hospital will assign their patients to a hospital-owned hospitalist provider. And just to give you an idea, the difference in what hospitalists do as consults in the hospital is hospital-owned 5 to 6 consults per patient. Independents, 1 to 2 consults per patient. Those are tens of thousands of dollars in difference in cost.
And John needs us to wrap
Okay,
up. But
good.
2 very quick important points. That coordination of care, look, it doesn't always run smoothly in hospitals. Anybody that's been in one, that's worked in one, or is practicing one knows that. I'm not allowed to tell you what we do at our MEC meetings every month,
Yep.
but I can tell you on a general basis, we spend a lot of time with departments talking, hey, why can't I get this from you? Or we look at things where they broke down, and it's communication.
Yep.
Secondly, on the ancillaries, you can profit from ancillaries. You have several folks in the room tonight that can talk to you about that, including the 2 folks that are going to talk to you about all the different things they can do to increase your revenue. Now, don't believe that Stark Law keeps you from that, and they're about to loosen. Larry's been at the front of this with the Stark Law input. They're about to loosen the Stark Laws, okay? After 25, 27 years.
It's called waivers.
And they're looking for
Yep.
waivers
Yep.
for things to build ACOs, clinically integrated networks,
Yep.
and IPAs. There's nothing to say you can't own in a well-integrated system in your own practice or participate in at least the professional components of a lot of ancillaries that are coming down the road, and that's the medical villages and the
Yeah.
allied health partners.
Yeah. And the marker on that is, are you truly reducing overall healthcare costs? If you're increasing healthcare costs, that is a true Stark violation. Would you agree?
I would agree.
Yeah, okay, good. All right.
So, all right,
Thank you. Thank you.